Thank you. I'm really pleased to be here with Shanti because she has such international experience. And anybody that knows me knows I'm very involved in the international community. I met her only recently when she came back to San Francisco, and she works at UCSF in their pharmacy department. But beforehand, she was very active in the uh, helping of AIDS internationally. And she was born in Mexico and came to the San Francisco when she was about 10 years old. And she went to school here in San Francisco, the public schools, before she went up to Davis, UC Davis. And um, I have met her father and her mother and her sister. So she is, well, she's coming back to her early roots here. I am so pleased to know that she is still involved with the AIDS community internationally with WHO and or its NGO, its nonprofits that it works with. Um, she is bilingual, French and Spanish, and that serves her well working in the international community. She got involved with AIDS education by volunteering when she was in at Davis, and she also volunteered and became an intern with WHO. And these kinds of volunteer situations, as we all know, uh, pass you to one group and another group where you can try yourselves out. So here she is, joining the international community with AIDS education, which is so impressive because AIDS welcome or not welcome is so handled so differently in different parts of the United States as well as the world. And so we're very fortunate to have Shanti join us to explain about what she observes and her experience. So welcome, Shanti.
Thank you, Mary Jane, for that introduction. And thanks to all of you for taking time out during this beautiful San Francisco day to spend an hour or so chatting about HIV and where we are now. And so let's just start off with a quick overview of what I'm hoping to cover. I think I'd like to start with setting the scene and just really describing the various players and what language is used in the international sector and how that's evolved over time, because I think that there's some really interesting lessons to be learned from that, that maybe isn't necessarily something that we really focused on in the United States, but something that was definitely important when we started talking about HIV globally. I'm going to then dive into the statistics to help you understand the situation before I start really then describing what the local context and responses are, which I think will really help better understand some of those numbers that I share with you. So I'm aiming to finish in time for a 30-minute discussion, but do feel free to ask any clarifying questions. You can put those in the chat and Jim will be monitoring those. At the end of every section of the presentation, we can revisit any of those clarifying questions, but I do hope to have 30 minutes at the end to have a more in-depth discussion and answer any questions that you might have to the extent that I can. Okay. So let's start by looking at who the players are, who are the actors when we talk about HIV and AIDS programming at the global level. And I think, this is a really broadly speaking categorization of the global level players. So we have, obviously, at the very global level, we have the UN organizations like UNAIDS and WHO. We also have the Global Fund to fight AIDS, TB, and malaria. And these three organizations really are focused on what are called normative functions. So during my time with WHO, where I served as a technical officer, a lot of the work that I did was really helping national governments develop the ways that they would be implementing programs to monitor and evaluate their HIV responses. So agencies like WHO and UNAIDS are technically referred to as specialized technical agencies, and they really provide guidance to countries and provide policies and strategies. They also establish global goals that we want to achieve as a global community. But you also have to remember that these agencies function under the auspices of all of their member states. And so some organizations, and I'll get into that a little bit more in the next couple of slides, they have over hundreds of countries that they represent, and each of them has a vested interest. So you can imagine the difficulty that it is to come together around consensus, around guidelines and around goals. And I think for that reason, a lot of the time when people think about the UN, they think of like a monumental organization that's really slow to respond, that isn't specific to the country needs. And a lot of that is because of the way they're set up. And when we talk about the country needs, that's when we move more to the national level. So all of the governments that are member states, they get these guidance, they get these goals, and it's their job really to adapt those to what the local context is. And it's also their job to look at the funding, about how they're going to invest their money in making the responses effective. And so in a lot of developing countries, that funding comes through bilateral money. So this is money from one government to another. And it includes loans from places like the World Bank, for example. But money can also come through the Global Fund for their specific responses. But there's also grants and projects that are funded largely through foreign assistance programs. So in the United States, we have the U.S. Agency for International Development, or USAID, and they're the ones that really invest heavily in supporting national governments and their response, not just for HIV, but for a multitude of programs. And just to put it all in context, you know, the United States has the most expensive healthcare system in the world. They spend, the US, according to the World Bank, spends over $10,000 per person per year on healthcare. And I just want to put that in perspective because some of our Western colleagues and partners in development, like the United Kingdom, they spend half of that. So they're spending about $5,000 per person. And then when we talk about the countries that my work has focused on, we're talking about some countries that are spending about $20 per head per year, like in the Democratic Republic of Congo, or in countries that we think of as middle income countries like Thailand, they're spending $275 per year per person. China, who we've been hearing a lot about, their expenditure is closer to $500 per year per person. So just to put it in perspective about the money that we're talking about these governments having at their disposal from their own internal resources to not only address HIV, but all of the healthcare programs that these countries are supporting within their national system. So you can see that there's obviously a huge gap there. And that's why some of these global organizations and funders like the Global Fund, like USAID, are really important partners in helping the governments really achieve and try to attain these goals and support their programs at the country level. Now, within countries, we have what's called the community level, or sometimes you'll hear it referred to as the subnational level. And that's really where we get to the service delivery part of the program. So this is really where the policies and guidelines hit the ground, right? And this is where we try to implement the services and enact all of those policies that have been adapted at the national level, but have been sent down from global agencies like UNAIDS and WHO. And so at that level, again, you know, bearing in mind these discrepancies in the funding and these gaps, a lot of the services that are delivered in the countries in which I've worked, these are supported by bilateral organizations like USAID, and they give money to international non-governmental organizations to implement the programs. A lot of them are only 3 to 5 year programs, so it's a cyclical approach, which has a lot of issues because obviously sustainability of programs over the long term is a challenge when we talk about HIV, where we're talking about putting people on treatment that they're going to be needing for the rest of their lives. You can imagine the havoc that this creates at the local level, where every 5 years the contract ends, the US government might reissue the contract, in which case all of the international NGOs actually bid for it. So there's a lot of dynamics at play at the community level that are very challenging for implementing not just HIV, but all of the programs that are funded by foreign governments at the country level. Additional barriers as well, when we talk about that government money, is that there might be limits and exclusions in terms of what can and can't be supported. So for example, under the previous administration, many organizations like Planned Parenthood International, which supports a lot of family planning and reproductive health services internationally, they lost their federal funding for activities because they provide abortions, which is really unfortunate, because if we look at, sorry? Oh. Because if we look at the full portfolio of what organizations like Planned Parenthood do, that's only 3% of their activities. In fact, they've been instrumental in helping improve the health of women and their children, not only in the United States, but also globally. So that's a very high, broad description of who the key players are and how they work together. And I just wanted to delve very quickly into each of the specific key organizations that we'll be talking about today. And so the first one is WHO, where I had the fortunate experience of being able to work with them for about 10 years. Their response to HIV was initiated in 1986 under Dr. Jonathan Mann, who some of you might have heard about. He was a really highly respected physician. He started working, I believe, in Zaire with responding to HIV when it was starting to become evident that Africa was being heavily hit by the epidemic. And then he came to WHO to establish this program, which quickly became the largest health program WHO had ever seen since its creation in 1948. UNAIDS was established and the size of the HIV program was reduced. And I'll talk a little bit about UNAIDS in a second. But basically then essentially WHO's program, which is when I joined it, really became much more focused around the health and the treatment. So really a lot of work then became much more focused around making sure that there was access to treatment and other biomedical interventions. As I mentioned before, the way that these UN organizations work is really with their member states. So just to put it into context, WHO has 194 member states. It works across the 6 regions. So we have, AFRO, which is the African Regional Office, and they support the work in Africa. We have AMRO, and that should be AMRO/PAHO. Just as an interesting tidbit, PAHO actually, the Pan American Health Organization based in Washington, D.C., also serves as the global or the regional arm for the Americas for the World Health Organization. But PAHO actually predates the World Health Organization. So they've been around longer than WHO. Then we have EMRO, which is the Middle East. We have Euro, which is offices in Copenhagen. The Southeast Asia office, which is CERO. And then we have WIPRO, the Western Pacific. And even within those 6 regional offices, we also support about 150 country offices. And in many regions of the world, probably excluding AMRO or PAHO, WHO plays a really fundamentally key role being a partner with the ministries of health in implementing and designing health programs. So they have a really monumental and important task at the global level and at the regional and country level in terms of supporting local government responses to health issues that affect those countries. As I mentioned, the normative role is really around developing guidelines, and for HIV specifically, that was really around the effective prevention and treatment of HIV. And the way that they get their money is that member states pay dues. So I'm sure that, when the previous administration withdrew from the WHO, it had a huge impact on WHO because their normative functions are funded through these fees. And the United States has always been a very important player within WHO and in supporting its work. And so you can imagine that it was a very devastating blow during the previous administration when this became apparent that the United States had this intention. I think for anybody working in my field, the last 4 years, to say the least, was a very trying and frightening time because a lot of funding was getting cut, and it really had an impact on the lives and quality of life of many people globally. So I think a lot of us are breathing a sigh of relief with the new administration and their reinvigorated interest in supporting this work. So UNAIDS, I want to mention them because they actually are a very unique organization. They were founded in July 1994, and a lot of this stems from Jonathan Mann's work. He started to really talk about HIV, not so much as a medical issue in the sense that it was a disease that needed a cure. What started becoming apparent very early on was that we had individuals and communities that were being impacted and didn't have access to care. And so we started to really, and he was fundamental in this, was really structuring the discussion about HIV around a human rights perspective and the importance of having what's called a multi-sectoral response to HIV. He realized early on that no matter how much medical interventions there were, which at the beginning there really wasn't much. At the very beginning, we were talking about palliative care. I still remember that when I started working in HIV, it was helping people die. We didn't have treatment in the international sector. And so a lot of the work was really around finding humane and dignified ways to help communities cope with the level of death they were seeing, helping families and grandparents in particular be able to take care of their grandchildren because their children had died of HIV, and helping those who had AIDS die in a dignified manner. And a lot of this, it became very clear very early on with the work of Jonathan Mann that we need a multi-sectoral approach that didn't look just at what the medical sector could do, but looking at what the impact was, how do we get nutrition? So the World Food Program got involved. How do we make sure that human rights are respected? So UNHCR got involved. How do we make sure that we have funding to support these programs? So the World Bank came on board. And so this became the first UN program that's called a co-sponsored program. So this is really the governmental structure of UNAIDS is a board that's made up of representatives of all of the UN agencies that support the work that they do. And to this day, it's still the only co-sponsored program of the United Nations. Some of the work that they do is really because they are a co-sponsored organization and they represent all of these various different organizations. A lot of the work that they do is really around developing global strategies, not looking just at what we can do in healthcare, but across the board in education, in food, like I mentioned, what we can do for children, what we can do for human rights. And so you'll see a lot of the strategies that come out of the UNAIDS are really these multi-sectoral strategies that are intended to help governments address HIV through all these various different dimensions. A lot of it is also around establishing goals. So we'll talk a little bit about the 90-90-90 goal that they've established. And they also bring in and serve as a repository of all of the HIV related data that we have at the country level and at the global level across every single country. So UNAIDS has a massively important role in being a steward of the response across all of the United Nations and in establishing these strategies and goals at a global level that we all strive to achieve. And so the current focus, and again, this is just to set the scene in terms of what it is that we're trying to achieve right now, is we have what's called the 90-90-90 goal. And that's really aimed at making sure that 90% of all the people living with HIV know their status, because we've made tremendous leaps and bounds towards making sure that people know their status, but we still have a way to go. And we want to make sure that of those 90%, that of the 90% of people that are diagnosed, they receive sustained ARV treatment and or antiretroviral therapy. And I'll talk about the importance of why we talk about sustainability as a key issue when we talk about HIV treatment in particular. And we want 90% of all people receiving ARVs to get virally suppressed. And at the very end, when we kind of revisit all of this and I talk about future direction, I have a small video that I think will put all of this in perspective in terms of why we want to make sure that we have sustained access to treatment for people, and especially people in developing countries, and why viral suppression is such a fundamentally important cornerstone of our strategy for defeating HIV. The last player I really want to mention at the global level is the Global Fund. So they were founded in 2002, and they were founded at the time when I was with WHO, and we provided a lot of technical assistance at that time to help them set up their program and be able to start their mission of giving and investing money into the fight for against HIV, tuberculosis, and malaria. One of the things that I did with them at the very beginning was I collaborated and coordinated their first M&E toolkit. So this was their first toolkit for monitoring and evaluating their investments in HIV. And they have grown tremendously since that time. They mobilize and invest more than $4 billion a year to support countries. And they work across the UN agencies in terms of supporting some of that technical assistance that governments need at the national level to be able to design their programs and strengthen their programs. And this is money that is very competitive. A lot of national governments rely on this money to be able to sustain their activities in these 3 program areas. And this was really, the three diseases were selected because they're the ones that were pretty much and still continue to be driving mortality in developing countries. So I know that we don't talk too much about tuberculosis and malaria, if at all, within the United States, but these are diseases, these are infectious diseases that are still hampering the ability of governments to really achieve successes in development. And they're very important for trying to control so that these countries can break out of their cycles of poverty and move forward with their broader development goals. And the third, or the fourth players that I wanted to talk about was really focusing on that community level and these INGOs that I mentioned, these international non-governments that are basically the ones that, to a large extent, they get money from the foreign government agencies like USAID to support implementation at the community level. And they provide a large part of HIV services in developing world. And some, I think when we traditionally think about NGOs, we really think about the grassroots types of community answers that are designed at the community level and implemented at the community level. But, I think people don't realize that these players are massively large organizations that provide services across the world. World Vision, for example, they have an annual budget in millions. So they have more resources than many other countries, like national government countries, to respond. So in 2001, just to kind of give you a little bit of perspective on this, the World Vision's budget was $2.8 billion. And that was bigger than the budget of all UN agencies combined. So we're not talking about that really grassroots level of NGOs. We're talking about a whole new group of INGOs that, to a large extent, a lot of them started coming into focus during the HIV epidemic because there was a lot of money in HIV. And so these local organizations, they really blossomed and started to become significant players in service delivery at the community level. And some of the things that it's really important to realize with these non-governmental agencies is that their focus is really on addressing gaps that the national government programs can't provide. And it'll come a little bit more into perspective when I start talking about the populations that we're targeting when we talk about HIV services. But a lot of the programs and a lot of the services in developing countries are provided by the government through the public health sector. And these are services that are really meant to be for the general population. But when we talk about HIV, we're really talking about subpopulations within the general population. And a lot of those individuals really are disenfranchised. They don't feel like they can access the public health services. So these types of organizations have a really unique niche space where they're able to design and deliver programs that really target those populations that are epidemiologically important for us to target when we talk about hampering and limiting the impact of the epidemic. Obviously, with these organizations, sustainability is always an issue because, as I mentioned previously, a lot of the money that they get comes from agencies like USAID that run on 3 to 5 year cycles. And so there's this constant issue of sustainability and this question of sustainability around the work that they do, which is always a challenge. I don't know the solution for it. I've lived through it for 20 plus years. It really does your head in, but you have to just persevere and keep on going. So that is just a quick overview of who the players are. And I think it was an important little segue into our main discussion, only because that way you see who it is that we're talking about and who are the main players at the international level. I don't know, Jim, were there any questions for clarification before we move on to terminology?
No, there's time in the chat, but I do have a question, even though if you're going to get into it later, fine, just let me know. But the 90-90-90, I guess that's a goal that
Yeah.
You have. And I was curious, you indicated that the goal was to have 90% of those who are receiving antivirals would respond to that, I guess. Is that why is it 100%? Is it because of the limitation of the drugs or compliance, or why not have a goal of 100%?
I think because realistically, we know we won't ever reach 100%, but I think it's also based on epidemiological modeling. And we know that if we get 90% of people on treatment, we will be able to control the epidemic. So it's basically a type of herd immunity, if you will. If we get 90% of the people on, we know that we'll be able to control the epidemic much more effectively.
Okay, thank you.
Sure. Okay, so if there are no more questions for that section, I just wanted to talk a little bit about terminology. So this is an interesting perspective, I think, for many who might have obviously lived through and seen the experience in the United States, and particularly the unique and tremendous experience in San Francisco. And I think it's important to also just see how that translates to the terminology and the way we speak about HIV on a global level. And so here are just 3 key terms that I think are important and interesting to talk about. You know, obviously when HIV, we started seeing the first cases in the United States in the 1980s, and the first terminology that was quickly replaced was GRID. I'm sure many of you might have recalled that, and that stands for gay-related immune deficiency. And a lot of that was because the cases were among young gay men. And so it suggested sexual transmission among that population. But that was quickly changed to HIV and to AIDS by CDC. But in parallel, at the time that we were starting to see cases here in the United States among the gay community, there were cases of a wasting disease that we were starting to see in Africa. So if you recall, you know, one of the medical manifestations of HIV, once it becomes full-blown AIDS, is people become incredibly thin, and there's a wasting syndrome that is associated with full-blown AIDS. And so in Africa, there were cases of this that were starting to be reported, and they started calling it the slim disease in many parts of Africa. But we then quickly progressed to talking about AIDS, which is acquired immune deficiency syndrome, and that's the full-blown result of being infected. So this is really during that period of 1989 to 1991. But as treatments became available and people started to be able to prolong their infectious period, but not necessarily progress to full-blown AIDS, we started talking much more about HIV. So nowadays, you'll notice that with the exception of organizations that have AIDS in their name, they're not necessarily going to change that. But the way that we talk about AIDS nowadays is we speak to more of HIV. And this is largely because now with the effectiveness of treatment, we're not really seeing AIDS per se. People aren't progressing to full-blown AIDS anymore. HIV now is what we talk about, and we talk about it within the context of being a chronic disease. The second term is, the second and third terms are really about terminology we use to describe the populations most affected by HIV. And this has really evolved over time and strives to be culturally appropriate. At the initiation, even today, we really strive to make efforts to focus on the risk behaviors and not labeling individuals. But a lot of it, interestingly enough, comes through the categorizations that we use nowadays. It's really kind of left there because of where money for the HIV response comes from. So USAID, for example, spends millions and millions of dollars on an annual basis to address the HIV epidemic globally, but they have to be accountable to Congress. So we need to be able to produce numbers that are categorized by the subpopulations that are most at risk in order for them to justify the expenditures and the use of this taxpayer money. So that's why you see the persistence in subcategorizations of populations, even though on the field level, what we're doing is really looking at risk behaviors. And based on those risk behaviors, we then are able to categorize individuals into subpopulations, which are then reported to these international agencies. So while in the US, we talk about the homosexual and gay populations being most affected, this is not something that we necessarily use in the international sector, largely because it implies a self-identity. And this isn't really applicable in many parts of the world, specifically in parts of the world where there are a lot of gender norms that still persist. So in places like Latin America and Africa, the male gender role is very strong and homosexuality isn't very widely accepted. And I'll talk a little bit more about that and show you some statistics later on. But we use the broad term of MSM, or men who have sex with men, in order to be able to capture not only individuals who might self-identify as gay, but also the men who engage in that behavior that puts them at greater risk for HIV. And the final one is around our population of sex workers. There's terms that have been used in the past like prostitute, but we use sex worker as the term more globally. And in this situation, we really focus on the behavior of sex work, which is really transactional behaviors that put women at risk. So in HIV programs, like I mentioned, we tend to classify people by their risk behaviors and not necessarily how they identify themselves. And what we do at the service delivery level with HIV programs a lot of the time is we'll do an initial risk assessment with individuals so that we can understand what specific behaviors they engage in. And we do that for two reasons. The first is, like I mentioned, it helps us categorize for our reporting accountability to programs. But the second is really because it allows us to really tailor then the services and the type of counseling and the type of discussions that we'll have with each individual person. So just as an example, when I first started working in HIV with WHO, a lot of the work that I did was in Africa. And a lot of what we were seeing there was that there were a lot of young women and they had what were called sugar daddies. And these sugar daddies were generally older men, often married, and they would offer to cover uniform or tuition costs for these young women in exchange for sex. And so while these girls, they wouldn't identify as a sex worker, and certainly we wouldn't call them sex workers, but because of that behavior, of that transactional nature of the behavior that was going on between her and this older man, we would categorize them as sex workers, quote unquote, for reporting purposes. And I think as a rule within the HIV community and when we do service delivery, we're very careful not to label the clients. I think all of us understand that this is something that when we are being funded by these foreign governments, it's something we really need to be mindful of, because it's something that we need to make sure we're able to justify how the money is being spent. Okay. All right. So any questions on terminology before we move to the evolution of the epidemiology?
Looks like we don't have anything in the chat.
Okay. So just a little bit about the evolution. So I think when HIV first started, when it first emerged, it was really an emergency response, and we didn't really have time to understand where it came from. We really didn't know much about it. In many ways, parallel to COVID today, right? I think every week we're learning new things about COVID. We're learning new things about the efficacy of the vaccination, of the vaccines that are available. And this was really happening with HIV when it first started. All of a sudden, we started seeing cases cropping up everywhere. And it's not until many years later that we were able to kind of do a little bit more digging. And we started to see that, there had been cases apparently that were being reported of, wasting disease as early as the 1920s in some places in Africa, and particularly in Congo, which is also where we see a lot of emergence of Ebola nowadays. And so we saw that we started to do a lot of these epidemiological studies and realized HIV had actually been with us for a really long time, but it wasn't until globalization started happening, where we started seeing trade routes, where we started seeing flights and connecting places that were otherwise in the past largely remote and isolated, that we started to really see HIV emerge. And so based on all of the evidence that we have to date, we estimate that the current epidemic, the one that we're living right now, really started in the mid to late 70s. And by the 1980s, it had really spread to 5 continents. By 1986, 85 countries were reporting close to 40,000 cases globally. Africa was reporting maybe around, in the mid 80s, they were reporting around 2,000 cases, where here in the Americas, we had over 31,000. And the reason I wanted to mention that is that it's not because Africa actually had less cases, it's just that they weren't able to report it and to keep track of them the way that the United States did. I think the Centers for Disease Control and Prevention is an incredibly admirable organization, in the sense that they are a wealth of data and they have systems in place to be able to track all of these things. And they really jumped on board when they started seeing really rare cases of cancer emerging in the United States. And it really raised a red flag for them, because these were types of skin cancer that we're seeing usually among older men of European descent, not necessarily young, healthy men otherwise. And so the CDC really got on board and started tracking it. And so that's why we have better numbers around what the HIV caseload looked like in the Americas, and in particular in the United States, as compared to other countries. By the late 1990s, there were over 300,000 cases that had been officially reported. But it was thought that closer to 8 to 10 million people were living with HIV worldwide. And in the early 90s was when the first tests became available. So up to that point, we really didn't have a way to test people. So what we were counting were really the people that showed up to the health system. So again, massive undercounting in the developing world, where people tend to stay at home and die at home, where there's very little and limited access to healthcare services. So we know that the numbers at the beginning of the epidemic were grossly underestimated in countries. And we see that now with the number of cases that we saw. But by 1993, we had about 2.5 million AIDS cases globally, and by the middle of 1995, we had about close to 5 million new cases, and we were able then to see that the majority of them were starting to affect the developing world. So we had over 2.5 million cases in Southeast Asia. And again, sub-Saharan Africa came in at like just under 2 million. But again, we know that that number grossly underestimates the number of people that were affected. In 1999, this is several years after the creation of the HIV program at WHO. WHO announced that AIDS was the 4th biggest cause of death worldwide, and it was the #1 killer in Africa. They estimated at that time that there were 33 million people living with HIV. So that counted for about 16,000 new infections a day, and 14 million people had died from AIDS since the start of the epidemic. So it started to really unfold quickly, but it wasn't until we were able to get HIV tests that we started to be able to track cases more reliably. But again, those tests became available in the early 90s in the United States, but it took a while for us to be able to get them into the developing world. And the same with treatment. So as I mentioned earlier, when I first engaged in HIV programming, a lot of it was about palliative care. It wasn't about providing treatment to people. And a lot of it was due to the fact that the initial HIV drugs, they were all under patent. And so they were extraordinarily expensive. Bear in mind that I shared with you that some countries spend anywhere from $18 to $500 a year per person per year on healthcare. Some of these HIV drugs that first came online, they were costing thousands of dollars a year per person. So you put it into perspective, you see that governments wouldn't have even had the amount of resources necessary to even provide these drugs. And so it was really important that in 2000, UNAIDS negotiated with 5 pharmaceutical companies to reduce the cost of these drugs so that they could get to developing countries. And in some cases, there were emergency declarations that were issued that allowed, in international law, it allowed us to break the patents. And that allowed companies like Cipla in India to become a major producer of low-cost drugs for the developing world. And it was a very interesting time to be at WHO then, because these negotiations were fraught with, they were very political. A lot of the pharmaceutical companies, they didn't want to give up their patents, and the threat of breaking international patents by making an emergency declaration was something that they saw as very threatening. But they really didn't have a vested interest in supplying the drugs necessarily, because even though a lot of people needed the drugs, they knew the countries weren't going to be able to pay for them. So there wasn't a market segment there for them. And so it wasn't until UNAIDS really stepped in and made these negotiations possible, and that certain organizations or companies like Cipla came on board, that we started for the first time really being able to provide treatment to people in the developing country. And bear in mind, this is 20 years after the start of the epidemic. So what do we look at? What are we talking about nowadays when we talk about HIV? So this is just a snapshot. There are about 38 million people who are living with HIV globally. 20% of those, we estimate, don't necessarily know their status. And so we do this based on data from the countries. We know when people are infected, we can trace their partners. So I think a lot of you have listened probably to the news about COVID and contact tracing. So that's something we do in HIV as well. And so knowing how the rate of effectiveness of the disease, we can calculate how many of the individuals that somebody might have been exposed to are infected. And that's how we get these estimates about the percentage of people that might not know their status. But you see here, Africa was always the hardest hit. I'm sure a lot of you saw back in the day, the really sad stories about deaths in communities in Africa, but it continues to be the region that's most impacted by HIV, with close to 20 million of individuals living in that region. And then we talk about the Western Central Africa and the Asia Pacific. So you see here that it really is those poorer regions of the world that are still disproportionately affected by this epidemic. And I think this is where we get to talk about a little bit of the populations that are most affected. And so this is really where you start to see the breakdown. So the global statistics are really all well and good, but I think what we need to do is really dig a little bit deeper and see who it is within those populations that are most affected by the epidemic. And you see here, you know, clients of sex workers still are an important population group. But our sex workers and people who inject drugs are most affected globally, as well as our men who have sex with men. And more, we're starting to get data on the transgender community who is at particular risk for infection. I think this slide is interesting. It's a lot of information, but I think the key takeaway is that we have started to see a decrease in the cases globally, which is really great. You know, you see Asia here is gone down by 9%. You know, some places like Eastern Europe and Central Asia, they've gone up. And the epidemic there is largely driven by injection drug use. And so that is the most efficient mode of transmission. You're essentially, if you're sharing drugs, if you're infected, you're essentially then re-injecting your blood into somebody else's bloodstream, which is you know, close to almost 100% effectiveness in terms of transmitting the virus. So that's why we're seeing this huge jump in Eastern Europe and Central Asia, where there've been a lot of political upheaval, a lot of new states with a lot of uncertainties. And so, you know, people tend to engage in more risk behaviors during those times. And we're seeing our injection drug population there is becoming really heavily affected. But globally, we're starting to see really a decrease globally, which I think is really speaks to all the efforts and all the hard work of so many organizations, individuals, and communities since the beginning of the epidemic. I don't know if we have any questions on some of the epidemiology that I went through.
So we don't have any chat. Does anyone want to unmute themselves if you have a question? The previous slide or two back, I think that you had the various, one more back.
Yeah.
I didn't understand the remaining population.
So that's the general population, Jim.
So these are people that are not infected?
So no, so this is all of the people infected. So about 46% of the individuals affected are what we would categorize as general population members. So individuals who don't necessarily engage in any specific type of risk behavior, but maybe they were infected through blood transfusions. I'm going to talk about that a little bit more in my next slides, because a lot of that 46% is actually women.
Okay, thank you.
Sure. All right. So why don't we talk about the response a little bit? So when we talk about groups that are disproportionately affected, women are disproportionately affected. In the late 1980s, WHO rolled out a three-pronged strategy for HIV control. So if you recall, I said one of their normative functions is to develop these kind of higher level global strategies about what we can do to respond to HIV. And this is a case where actually I did my graduate school thesis on their strategy, because it was a real case of where a global strategy needed to really look at the context in which individuals lived in order to function. And this strategy, the three prongs that it focused on was 1, around monogamy, 2, around abstinence from sex, and 3, around condom use. And this was a strategy that was particularly targeted at women and women in Africa, because this was the continent, again, that was the most affected by HIV. But there were a lot of cultural norms that if we took this strategy and just tried to implement it in Africa, it was doomed to fail. And this was largely because, you know, it didn't acknowledge the fact that women within their relationships are often monogamous. But a lot of the time in Africa, you see that the patterns this gender norm. It's perfectly allowable for a man to have multiple sexual partners. So while a woman might be monogamous to her partner, didn't imply that her partner was monogamous to her. Abstinence was also not really a realistic option for a lot of the women in this, in particular in this subcontinent, but also in some other subcontinents out, in some other continents, I would also argue. And this was really because, at least in Africa, which is where I focused my thesis on, the economic well-being and security of women was really largely based on the number of children that they had. And abstinence in that context isn't really an option for them, because a lot of these countries still at that time did not give land rights to women. Women in many countries weren't able to open up bank accounts without their husband's permission. They were probably the ones that were working out in the marketplace, but the money they earned was turned over to their husbands. So you're talking about a really complex environment where a woman's security was really around her marriage and her children. And so abstinence was a very challenging message to be sending to these women when they weren't able to really implement that. And then the last one was condom use. And in many places you see the women, obviously we've talked about the importance of childbearing and child rearing, but it's also, condom use was in a lot of societies, at least at that time, it was really something that was seen that you use them when you're not having sex with your regular partner. And so if a woman asked her husband to wear a condom, it would probably be viewed with suspicion, and at worst it might be viewed as admission of having had another partner. And so both of those situations really put a woman at risk for intimate partner violence. And so I think WHO really learned from this, and subsequent strategies, you saw them move more towards approaches that involved men. So looking more at trying to engage men in the response as well, acknowledging the fact that we couldn't, even though women were being disproportionately affected, they weren't empowered and in a position within their societies to be able to exercise the choices and utilize the approaches that were available to them. So sex workers, so they are 13 more times likely to get HIV compared to the general population. And this is really due to becoming, being economically vulnerable, unable to negotiate consistent condom use. There are a number of reasons that women involved in sex work are able to, there are a lot of barriers and reasons at the contextual level why these women aren't able to necessarily use the condoms that are at their disposal. And, I think it's really important when we talk about sex work to realize that a lot of the women who are engaged in this, it's not out of desire, it's really out of a necessity. So often they have limited education. A lot of them are mothers, and they're working to provide money to their families. So a lot of cases I've seen is, these women have children, and they usually live with their extended family. And so they're sending money back. Their families often don't know that they're engaged in sex work. And I recall, when I was working in Mexico, I was working with the sex worker community, and I was speaking with a sex worker, and she shared with me that this wasn't her choice, to be engaged in this, but she had to leave school when she was very young, and she really couldn't find any other work because literacy was an issue. And so she fell into sex work, and she had a family and she had children, and nobody knew, her children didn't know that she was engaged in sex work, but she continued to do it because it was the only way that she could get money. And what she was ultimately doing was saving this money so that she could send her children to school so they'd have opportunities that she didn't. And I saw many similar cases as well in Thailand, where, as I mentioned, women would engage in sex work and send the money back home, and their families had no idea. They thought that their young daughters had gone to Bangkok to work as waitresses in bars and things, but weren't aware that they were also engaging in sex work. And because women who are trading sex for money are often economically disadvantaged. There might be educational and literacy issues. A lot of the time what might happen, and what I saw happening a lot in Africa, was that if a client offered to pay more money if the woman wouldn't ask them to use a condom, these women would actually accept that offer. And so that really put them a lot of at a lot of increased risk. And it's interesting because sex work is illegal in many countries, but it still occurs. This picture is from Thailand, and this is in Bangkok. And in Bangkok, there are what are called a lot of entertainment districts. So these are subsections of the city where you have a lot of bars and like hourly hotels, and they're all concentrated in an area. And outside of these, you see women like the ones pictured here, and they're advertising cheap beer to draw and lure customers in. And once you go inside these places, what happens is, girls are dancing on the tables and walking around in the bars and serving drinks. And all of them have these big numbers pinned onto their clothes. And so if a client is interested in taking the girl out off the premises, he might have a discussion with the bar manager or the bartender and say, this number girl is the one that I'm interested in. And what ends up happening is it's called you buy her out. And so essentially what this means is that the client will pay the bartender or the bar manager a certain amount of money in order for to cover the costs the bar argues. This is the fee that it costs us to take our waitress outside of the hotel or outside of the bar for a few hours. This is what it's going to cost us because she's not going to be working here. So you reimburse us. You can take her out. And the girl will, and the client will generally go to, an hourly hotel that's just down the block. And once she finishes with the client, what she'll do is she'll come back to the bar. So this is what's happening on a daily basis, even in countries where sex work is illegal. Okay, and here I want to share a short video here with you just to talk about Thailand a little bit more. And this is a case of a very successful approach to HIV prevention and control. This is the case of Dr. Michai, and he's a leader in family planning and HIV prevention in the country. And I just want to share with you
Michai Baraveda is a politician and activist in Thailand who's improved the lives of millions with groundbreaking family planning and HIV prevention programs. Thanks to his innovative efforts to promote contraception, he's best known by his nickname, Mr. Condom.
My name is Michai Viratwaitya. 50 years ago, I realized that Thailand needed to reduce its population growth. I introduced a system of community-based distribution of contraceptives to supply pills and condoms to their villages. So that was the beginning. And luckily, after about 22 years, we were able to bring down the population growth rate from 7 children per family to under 2. Then soon after that, HIV hit Thailand in the mid-1980s. People didn't know very much about it, and the government was concerned that if we talked about it, it would drive away tourism. We had to let the public understand about HIV, what HIV was, how did you get it, and how do you not get it. Eventually, we got a system passed, educated the Thai public, we trained everybody. We used the condom to promote what family planning is supposed to be, and it generated interest. You could use it as a balloon, and it made people laugh. I started giving out condoms to help to spread the message. So we used every method we could, and we got school children to have relay races with condoms, condom blowing championships, so they weren't embarrassed by the condoms. And that's the issue, that they could then talk about other aspects of family planning. Soon after the year 2000, the United Nations said that there was a decline in 90% of new infections during that period. 8 million people had been prevented from being infected. One columnist wrote a story, they call it the Michai story. We will now call the condom by this name, Michai. And now it is officially registered as a proper name for condoms. We have to wake up again to educate the public. The risk is now with the younger generation. The numbers are far lower, but the risk is still there.
So I think a really good example of what you can learn from other programs and scale it to also address current public health emergencies. And Thailand has been, as Michai mentioned in his presentation, in this video, they were really successful in controlling the epidemic particularly among sex workers, and they had what was called the 100% condom use policy. And the way that this worked was that a woman who worked in one of these entertainment zones, like I mentioned, they were generally affiliated with a bar, and they would have a little booklet, and every month they would have to go to a public clinic and get tested for HIV and sexually transmitted infections. If the woman came back with an infection, the way that the government responded was that the owner or manager of the bar would be charged a fee. So essentially, for any woman that was found to be have an STI, including HIV, the manager and owner of the bars were held responsible for that, and they had to pay really huge penalties. So there was really an interest in making sure that all of the women that worked within your establishments used condoms. Unfortunately, I think, one of the hidden things about this particular response was that once a woman tested positive, she was fired from those bars, and she obviously wasn't able to work anymore. And so what that ended up resulting in was a lot of these women then went underground, and instead of being affiliated with a bar, they would go to the street corners and still continue with the work that they were doing, but outside of that safety net of being able to still access the healthcare services that they needed. So there were some, undesirable side effects to the 100% condom use policy, which isn't actually used in Thailand anymore. But overall, I think it was really successful in curbing the epidemic. But again, it's one of those examples that the greater good outdid the individual rights in those particular cases, and I think that's a really good example of it. The second population that we're talking about is the population of men who have sex with men, and so again, they're incredibly high risk individuals. They're 27 times more likely to be at risk for HIV. A lot of that is not just because of the behavioral risk that's that is introduced by the relations that this population has, but a lot of it is also the cultural factors, including being fearful of experiencing discrimination, moral judgment, and mistreatment. So a lot of men also don't identify as same-sex, as having an inclination towards same-sex relationships. So it makes this population particularly vulnerable. The legal situation in Africa, we have a lot of countries where homosexuality and same-sex relationships are still illegal. And so within those contexts, it's really difficult for men who engage in these behaviors to feel comfortable accessing the services that are available to them. And in my next slide, I want to share with you, this is the continent of Africa, and this is a mapping done by Amnesty International. And this is 2 years old or 3 years old now, but it shows you the extent to which same-sex behavior is illegal. And you'll see that in the majority of countries in Africa, it's still considered illegal. So there's a penalty if you're charged, if you're found to or admit to engaging in these behaviors. There's also countries where there's a death penalty, and largely those are very conservative countries to some extent, and very few countries actually have legalized same-sex behaviors, and in those countries it's much easier to function because you're able to set up NGOs and other types of responses at the community level. But in a large majority of countries where it's still illegal, it really poses a challenge in terms of reaching these populations. And so, for example, I'm working right now with a lot of West African countries, and you can see that some of them, are still, Burundi, for example, which is one of the countries that I'm providing support in right now. Homosexuality is illegal, but the program is focusing on men who have sex with men. And what we have to do to protect these men and the clinics that are there to serve them is often we're not able to disclose the address of the clinic. And so we have to wait for somebody to reach out to us and then communicate to them where they can go for services, because having that information available on the web or through some of the other fora that MSM might use to find partners in sexual and reproductive health services, it would be a really high risk for us to be able to advertise openly that we were providing those services to them. So a lot of barriers to providing services that are applicable for a high-risk population due to the policies and laws that are in place, which really serve as a great hindrance to being able to reach these populations. The final population I really want to talk about was transgender women. So, you know, they are incredibly high risk, and that is not only because of the type of sexual behavior they engage in, but transgender individuals are particularly marginalized in a lot of countries. One of the things that I do find really interesting, and I discovered this through my 10 years in Southeast Asia, is that there is a culturally important role for transgender individuals in Southeast Asia. They do actually have a role in the culture, and traditionally these were seen as entertainers in the courts. But even in light of having a position in society, they're still very marginalized and really at the bottom of society in many countries. Interestingly, in Thailand, you know, it's a Buddhist country, and you know, people believe that if somebody is transgender, it's because they did something in their previous life. And I believe with if you see somebody who's transgender, the common thing people will say is like, oh, they had an affair in their previous life, so now they've come back as a transgender individual. But you know, nothing is held against them as an individual today because it was a past life transgression. But even then, you do still see that transgender individuals are really marginalized throughout the region. And, you know, in some countries, like in Africa, I mean, there's the violence towards transgender individuals is particularly high. But even in the Pacific where I worked, I did a study in Papua New Guinea and in Bangladesh looking at transgender individuals, the violence towards them, just trying to really generate a body of evidence in terms of, you know, how large are these population sizes, and, you know, what risks do they face? And overwhelmingly, it was violence. And unfortunately, a lot of that violence was through police who would arrest them, beat them up, rape them, and harass them. And a lot of the time, that's because this particular population doesn't really have a social support network in place. The transgender community is very close-knit and insular because there aren't very many services that are available to them. And there was really, I think, a misservice done for a long time, you know, with a lot of the programs that NGOs were doing. And this was largely driven by the way that funding worked. So USAID, for example, for a long time would have the umbrella of MSM and then have transgender populations under that. But obviously, if you're talking about a population who identifies as female, MSM services are not going to be applicable to them. And so I'm really happy that, you know, after a lot of fighting and a lot of discussion and a lot of generation of evidence into really informed policy, we were finally successful, at least in Thailand, to get investment by the US government. And before I left Thailand, we finally opened the first national transgender specific clinic, which was monumental. I think that was about 5 or 6 years of really consistent advocacy for the services. And nowadays, the US government reporting does break out transgender individuals as their own population. So I think there's been a huge amount of progress for a population that was really neglected for a very long time and at incredibly high risk of getting infected by HIV. So a huge success, still a lot more work to go. I think I just want to finish up by just a few slides talking about moving forward. And I just really want to share with you another quick video. I really think this one's important because it'll describe much better than I can the biomedical successes that we've had and why, in particular, these are really important to us. I think one of the things is that, you know, the vaccine development has proved to be incredibly challenging. I don't know if we'll ever get there. And so the treatment and drugs that we have nowadays for HIV are really the solution and the key for helping us control the epidemic. And in this TED Talk, I think they're going to give a much nicer overview about why that is.
The world is getting closer to achieving one of the most important public health goals of our time, eradicating HIV. And to do this, we won't even have to cure the disease. We simply have to stop HIV from being transmitted until eventually it fizzles out. Once, this goal would have seemed impossible. HIV has caused millions of deaths and is one of the most devastating diseases that humanity has ever known. But we're now at a point where new advances such as one-pill, once-a-day medications are helping us tackle HIV in effective ways. HIV is a retrovirus, meaning it integrates copies of itself into an infected cell's DNA, allowing it to replicate and infect other cells. HIV has evolved numerous ways to evade the human immune system, which makes it difficult to cure. But by developing ways to block HIV replication, we can stop the spread of HIV itself. That's where antiretrovirals, aka ARVs, come in. ARVs are a group of drugs which work in different ways to combat HIV. Some block HIV's access into immune cells, and others work by stopping the virus itself from replicating. ARVs also work preventatively in people who don't have HIV. This type of approach is called pre-exposure prophylaxis, or PrEP. PrEP works by accumulating in a person's body and preventing HIV from establishing itself. That means an HIV-negative person who may be at risk of contracting the disease can take certain ARVs to protect themselves before they become exposed. Here's where it gets especially interesting. In people with HIV, ARVs can also dramatically reduce HIV transmission. This is called treatment as prevention. On a global scale, this has the potential to end the HIV epidemic. It's based on the idea that someone with HIV who takes ARVs can lower the virus level in their bodies until it becomes undetectable. That doesn't mean the virus is gone. It could still be lurking within cells, ready to reactivate if treatment stops. But so long as it's kept dormant with drugs, HIV remains undetectable. And when HIV is undetectable, it's untransmittable too. In theory, this means that by testing everyone who's at risk of HIV and treating those who test positive, we could stop transmission and eventually eradicate HIV. In the real world, however, things are more complex. Many at-risk HIV-negative people across the world do not have access to PrEP or ARVs, and those who are HIV positive may experience challenges to taking ARVs. These problems are often greatest in countries where the burden of HIV is highest. Getting these medications depends on access to a functioning healthcare system, and this isn't something everyone has. That's part of the reason why stopping the spread of HIV for good will require a significant investment of resources to improve those systems. One study carried out by UNAIDS estimated that between $20 to $30 billion per year would be needed to achieve a nearly 90% reduction in new HIV infections by 2030. This investment would ensure more people would get tested in the first place, and more would be able to access and maintain treatment. Achieving this goal and improving healthcare in general is in everyone's best interest, from individual people to society as a whole. We have roadmaps that could allow us to bring the HIV epidemic to an end in the near future, with the possibility of eradicating the disease altogether several generations in the future. In the period from 1996 to 2017, we almost halved the number of new HIV infections. And for the millions of people who still live with the virus, ARV treatments enable most to lead long and healthy lives. With continued and increased investments, we can get transmission rates low enough to end HIV once and for all. A world without HIV is no longer inconceivable. It's closer than ever. The progress we've made in treating and preventing HIV is incredible, but that doesn't mean we should stop searching for a cure. Learn more about the challenges of curing HIV.
So that was just an overview of the biomedical approach to controlling HIV. And I think that's the global strategy that we're really aiming for. Obviously, we didn't take into account things like COVID, where, we had all of a sudden a lot of challenges in terms of continuing that access to care. If you recall at the very beginning, I talked about the importance of sustainable access to treatment. And a lot of it has to do with the fact that HIV is a highly mutable virus that can quickly develop resistance to treatment if it's stopped and then reinitiated several times. So the importance of maintaining access to treatment for those individuals who are already on treatment is paramount. And so a lot of the challenges that COVID had on us was that, services were essentially closed and it was difficult for people to access those services and get their treatment. And so there are a lot of opportunities, I think, moving forward that include, continuing not only the biomedical interventions and making sure that people are tested and know their treatment and know their status and get the treatment they need, but also addressing that multi-sectoral approach, because I do believe that we've kind of reached that point of where we're plateauing with the biomedical interventions. And it's really going to be important to have some more of a socioeconomic and cultural intervention put into place so that we can break down the final barriers to accessing services that individuals affected by and infected with HIV need. And a lot of that, I think, I mentioned the challenges of COVID, but I think that there's been a lot of lessons learned with COVID. And some of the work that I've been doing with NGOs right now has been bringing their services online. And that has increased the ability of individuals to talk to their doctors and talk to the clinics that they get access to treatment at, and be able to arrange for places for them to get their treatments continually throughout the pandemic. And there are a lot of opportunities, I think, as we move forward to using virtual environments for people to access services. And this is largely because in a lot of developing countries, unlike Western Europe and the United States, these countries moved on to mobile platforms and mobile use much earlier than we did. And so penetration of these types of technologies is actually relatively high, which I know for a lot of individuals might be a little counterintuitive, but it does give us a lot of opportunities moving forward to be able to address the next steps. And so in closing, I know we kind of ran out of time, so I'm just going to quickly, there is optimism and hope that it can be contained. And I think there are a lot of important lessons that we can learn from HIV and apply to some of these new and emerging diseases that we see in the world today. So thank you very much. I apologize that we went over so much, but I'm happy to take some questions in the remainder of time.
Okay, we have one in the chat. Says, going back to the 90-90-90 program, what were or are the levels actually achieved?
So again, that was pretty much, it was on a country by country basis. We're still working on that particular goal. They've just reissued it through 2030. So I think, again, we didn't anticipate COVID, and that had a huge impact.
So your slide indicated, I think it was like $30 billion or so would be needed to provide the treatment as well as prophylactic drugs. Yeah. Is that likely to happen, and where will that money come from?
I'm not really sure, Jim. That's a great question. I think that a lot of this money, it's the money that UNAIDS gets and WHO gets for from their member states for the HIV response. The United States has invested a huge amount through PEPFAR, the President's Emergency Relief Plan, and they're still continuing to do so. A lot of private foundations are also supporting the work. I'm not sure to what that all amounts to on an annual scale, but certainly there are resources available. And as drug prices lower and patents expire, I think there's opportunity there for finding ways to achieve access to all.
Okay, so PrEP is relatively new, I think, in this country. Is it available all in like the third world?
It is. I mean, PrEP is essentially ARVs, but just used for a different purpose. So at the country level in Africa, what we do is we repurpose drugs for treatment, for PrEP, and also for PEP, which we didn't talk about, but that's post-exposure. So in the cases of domestic or sexual assault or accidental exposure in the workplace, we can give the antiretroviral drugs to individuals to try to hope that that reduces their likelihood of getting infected.
Are there any other questions anyone has? Okay, I don't see any. So Mary Jane, would you like to use those words?
Mary has a question.
I don't have a question. I just want to make a statement. I taught in Lesotho in Africa in the 80s, and it is particular to the women. We visited with the choir in 2018. I didn't go to the village that I taught in. I just stayed in the capital of Maseru. But you know, that's a kingdom, and it's basically poverty. It's poverty. I mean, that's the issue. I mean, we can't do anything, you know, because they are so poor. Yeah. Anyway, that's my statement. But thank you for all you've done. It's remarkable.
Yes, I would like to thank Shanti on behalf of the Unitarian Church in San Francisco for your excellent presentation. I hope the recording is shared more widely, because I'm sure other people who haven't had an opportunity to have such specific information would be very interested in what you said today. And you said it in a manner for us non-techies, non-medical people. It was so clear. We really appreciate your giving of your time and your information to help us better understand the situation of HIV today. Thank you very much.
Thank you, Mary Jane.
Very good.
Thanks, everyone.
Bye-bye.
Bye.
Bye.
Bye.